Good evening and welcome. I'm Jean Johnson, a librarian at Stanford Health Library. Thank you for joining us at tonight's talk, Navigating Life with Chronic Pain. It is my pleasure to introduce our speaker tonight, Sean Mackey. Dr. Mackey is the Redlich Professor of Anesthesiology, Perioperative and Pain Medicine, Chief of the Division of Pain Medicine, and Director of the Stanford Systems Neuroscience and Pain Lab at Stanford University. Throughout our program, please enter your questions in the Q&A box at the bottom of your screen. Please remember our speaker's advice is for a general population. Do consult your own physician for specific advice. At the end of the talk, Dr. Mackey will answer as many questions as time allows. All right, Doctor, I'll turn it over to you.
Great. Thank you, Jean, and thank you for the invitation to come and spend the evening with you. I am delighted to be here. I'm Sean Mackey, and as was mentioned, I'm a professor and chief of the division at Stanford. I'm a physician scientist by training, meaning that I do both research, clinical care, and also educating the next generation of people who are going to take care of those with pain and research the topic of pain. And my goal today is to set the stage for what will be a series on different topics related to pain over the next number of weeks. And as such, I'm going to be giving an overview and setting a foundation for everybody that I hope will provide you the information you will need for the other talks that are going to come after mine. I've entitled this lecture, Understanding Pain, the Body, the Brain, and then the Experience. My goals in this talk are once again to provide a foundation. I'm going to talk a bit about the problem of pain, why it's such a big deal in society, why it's probably a big deal for many of the listeners here. I'll be talking about some of the basic the science of pain. I want to set a grounding for you to understand what pain is and what pain is not. You're going to find that much of what we have been taught and what we learn about pain is all wrong. And by giving you a solid foundation and the basics, the lectures that come forward afterwards, as well as your own education around pain, are going to be a whole lot easier. I'm going to then dive into a bit of what we do at Stanford in the care of somebody with pain from a multidisciplinary standpoint and define what that means and the different tools that we can bring to bear. And then lastly, I'm going to take a few minutes to talk about the future and where things are going, because I want to give you some hope. As I mentioned, I'm a physician scientist, and I'm actively researching new treatments for pain, new ways of better assessing and diagnosing pain and treating it. And I want to share with you some of the cool work that we're doing and what we believe the future holds. So let's dive into this, shall we? Let's start with the personal experience of pain. And this person is Susan. Susan is in her 40s. She has 2 children. She has a combination of fibromyalgia, back pain, neck pain. She gets migraines. On top of that, she has significant sleep disturbances. Her mood is altered. And she's found herself withdrawing from her family and friends as a consequence of her pain. And Susan is just like the other 50 to 100 million Americans that have chronic pain in our society. Now, this number of 100 million Americans came out of an Institute of Medicine report on pain that I was an author of and part of this committee. And we did a study to assess the burden of pain in society and found it's about 1 in 3. Now, that 1 in 3 includes people on one end of the spectrum who self-manage their pain at home. It's kind of like my father, who just dealt with it, wouldn't take any advice, not even from me, and just kind of self-managed, all the way to those who end up in our clinic at a major academic center. We know that there are 20 million or so who have something called high impact chronic pain. This was a term that we introduced in the national pain strategy that I co-led for our country. And this is pain that has significant restrictions on people's activities of daily living. This is the more severe, more impactful type of pain, and it has a tremendous impact on people. We have so many millions that it truly is a public health crisis, and barely a day or a week goes by when you don't see something in the press related to this discussion of the problem of pain. And it's only getting worse. And why? It's getting worse because we're doing a much better job in keeping people alive, because our medical system is prolonging life. It is helping people survive cancer, but the cancer treatments lead to chronic pain. It's helping people survive trauma, but that survival often is associated with chronic pain. Surgery has anywhere from a 5 to 30% incidence of having chronic pain after surgery. All of this is a consequence of our success and the unintended consequences of it. And we need to do something about it as a society. It's helpful in understanding pain to understand where our beliefs, our understandings of pain came from. I think this story is going to resonate with you. Much of our understanding of pain came from this guy, Rene Descartes, a 17th century French philosopher who's responsible for many aspects of modern philosophical theories and understandings. He's responsible for Cartesian geometry, which we all learned in grade school. And he also put forward the first mechanistic perspective on pain. And his mechanistic perspective was that pain was this reflexive mechanism that had a linear relationship between the stimulus and your experience. There was a one-to-one relationship. Now, before Rene Descartes, all models of pain were either thought to be due to evil humors or judgment and punishment from God. It was not grounded in any type of model. So he put forward the first one. Unfortunately, it was wrong. It was terribly, terribly wrong. Unfortunately, that model persisted with us for hundreds and hundreds of years, even to today. In fact, much of society still views pain in this dualistic, very simple linear model, and I'm going to work to dismantle that with you. When understanding a new area, it's helpful to understand the language that people use. And when we talk about pain, I believe it'll be of help to you to understand what the actual definition of pain is that's accepted within the scientific and medical community. It's defined, and I'm going to give you the short version here, an unpleasant sensory and emotional experience associated with or resembling that associated with actual potential tissue damage. Just remember, it is an unpleasant sensory and emotional experience that's associated or may be associated with tissue damage. By defining it as an experience, it defines it as something subjective. Each of us owns our own pain, experiences our own pain. It's unique to each and every one of us. And that's a key factor, a key feature in understanding pain. Now, in breaking pain down into the physiology of pain, how it all starts, where does it go, how does it become this perception of pain, let me bring you to this very simple diagram from Scientific American. Pain all starts typically with some sort of a stimulus. It could be a pressure stimulus. It could be a burn. It could be a cut. In this case, it was injection of capsaicin, the stuff that makes red hot chili peppers hot, in an experimental pain model. It all does the same thing. It activates little sensors here in our tissues. These sensors are called nociceptors. It's a Greek term, nociceptor, and it is a transducer that converts that mechanical energy, thermal energy, into a little electrochemical impulse. And that transducer is just like other type of transducers that we use every single day. This microphone I'm talking into is a transducer converting sound energy into electrical energy. So we've got untold millions of these transducers, these nociceptors, all throughout our body. And the purpose of those nociceptors are to signal during injury. That's what they do. And they detect different stimuli. They transmit those signals up nerve fiber types into the spinal cord in the back part of our spinal cord that goes up and down our spine. And they send these signals over to the other side, and they cross over and they head up to the brain. Now, the key thing to note here is that everything going on in your hand, right here, if you hit your thumb with a hammer, if you cut yourself, or wherever you feel pain, it's actually not pain that is going on in that body part. It's nociception. And it's an important distinction, and I'm going to tell you why. The reason is these signals that come up all get modulated or changed. They get amplified, increased, and they get decreased in the spinal cord and then also up in the brain. And they shape those nociceptive signals coming up that ultimately become the perception of pain. Now, this story wouldn't be complete if we didn't have some way of controlling all the signals bombarding us on a second by second basis. And so we've developed over millennia these pathways that come down from the brain and synapse again in the spinal cord that serve the purpose to turn down the signals heading up. It's this big closed loop feedback system that works beautifully when we're in a normal situation. The problem is when we're not in a normal situation. So we exist in what I refer to as this yin and yang of ascending signals coming in from our body, these signals heading in from our periphery, our bodily parts, up into our brain, balanced by a set of inhibitory signals coming down. And in a normal situation, we're in a nice balance and we're not experiencing pain. But what can happen that can lead to pain is either too much of these signals heading up, maybe through an injury, maybe through an old nerve injury where you're still having spontaneous firing of your nerves. The other way to get pain is when you don't have enough inhibition. You don't have enough of the signals turning it down. That can occur in conditions like diabetes, fibromyalgia, where we know that there are impairments in these inhibitory systems. Now, there's something else that occurs with all of us after an injury, and it's a term called central sensitization. It's forgive the jargon. I'll explain it to you. It'll become clear. Think back to the last time that you cut your hand, or you had a cut or an injury anywhere. What happened is, if you look at that figure, you get a release of inflammatory chemicals around that area. They're called bradykinin, histamine, cytokines, interleukins. What they cause is it causes redness and swelling and heat in that area. We call that primary hyperalgesia. Primary because it's in the primary site. But then if you think back, you go to bed, you wake up the next day, and doesn't your whole hand feel stiff and aching and sore? And the area that's sensitive is now expanded well beyond what was originally injured. Well, what's happened overnight is that your central nervous system, your brain and your spinal cord, have completely rewired overnight. And they have expanded the area that it perceives as painful. If you were to look at the tissue outside here, the tissue is entirely normal, but it hurts. Why? Because we developed these mechanisms to serve as a survival signal for us. Because back in the cave people days, when we got injured, we were better off going into a cave and letting things heal up than immediately going out and fighting the saber-toothed tiger, because we'd get eaten. Now, what happens over time is we heal, those central changes go away, the primary changes go away, we go about our business. The problem with chronic pain, we've learned, these signals don't turn off. The tissue may heal, or mostly heal all up, but that central sensitization is still playing a role. And we believe that that is a major reason for a number of the chronic pain conditions that we face. Now, I'm going to move more into the brain, which is a favorite area of mine, and I'm going to share with you some of the findings that we have had. I do a lot of work in brain imaging, which is a way of opening windows into your brain to see where pain is processed and perceived, to see how and why it's amplified, to see why it becomes persistent over time, and to understand the unique nature of human pain. And what we've learned is that we're able to map to different brain regions and systems many of the different functions of the brain and their associated role with pain. So we know that there are these areas in the anterior cingulate cortex involved with some of the emotional and unpleasantness aspect of pain. We know that there's some of these frontal areas of the brain, the prefrontal cortex, involved with evaluating pain. What does it mean to me? What am I going to need to do to get away from the pain? We know that there are these sensory systems back here that encode some of the intensity of pain and the sensory qualities of it, and on and on and on. The key thing is each of these brain regions, we've learned, can serve as targets for treating pain. That we can hit pain at various parts along these pain processing pathways, and we can reduce it. Sometimes we can knock it out. The key is, and I'm going to come back to this multiple times, is we want to be hitting pain in as many different parts of these pathways as we can. From out in the periphery, where we're attacking nociception, through the peripheral nerves, the spinal cord, and the brain. Speaking of treating the brain, one of the novel treatments that we have worked on is something called transcranial magnetic stimulation, where we do non-invasive brain zapping with a magnet that we pulse, and we can stimulate different brain regions. And we've been able to publish and show that we can provide some durable benefit in some patients. And we've been giving that away through some philanthropic donations and providing that as a service to patients with pain. Now, I want to move into some different aspects of pain that I think are important for people to understand. One, a key one here, everybody perceives pain differently to the same stimulus. And I'm going to come back to that. We also know there's high variability in who's going to develop chronic pain after an injury or after surgery. And we also know there is huge variability in people's responses to pain medications and treatment in general. And this in part has led to that very frustrating trial and error process that people go through, seeing physician after physician or treatment after treatment until they find something that works. Now, moving more into that individual difference aspect. This was a study done over 20 years ago. And by the way, these slides, I pull straight out of the slides that I give to medical students and also medical professionals. And so I haven't really changed them. I apologize if they're a little jargony, but listen to my voice and I'm going to explain what you really need to know if there's jargon there. This was a study in which they took 500 healthy people, gave a 49 degrees Celsius stimulus, it's about 121 degrees Fahrenheit, to 500 people. And what they found, incredibly, was this huge variation of how people reported pain. Some were down here in the bottom and said, no, it's not painful at all. Others said, yeah, it's about here a 20 out of 100, here about a 50 out of 100. And some were like, oh my God, this is almost the most painful thing I've ever experienced. Get it off me immediately. Wide range of responses to the same stimulus. We've learned that there are factors that contribute to this. There are genetic factors that cause increased sensitivity. We know that when people are anxious, when they're fearful, and when they haven't slept, that they have increased sensitivity to pain. I'm going to get into more of this. I do this same type of, I call it a demonstration because I can't experiment on our medical students without their permission. But I teach the medical students these same classes that I'm teaching you. But what I have them do is a demonstration. They come in and they put their arm into an ice water bath for 15 seconds, and then they pull it out. and they whisper into my research coordinator's ear, and at the end we tabulate their pain score, and this is what we typically get. This is about 6 years of medical students. And the purpose of this is to show these young physicians that everybody's pain is different and that you cannot ever project your experience of pain onto somebody else. And we're very careful about getting that message across because we see far too much of that in society. We've mapped out, this was a study done by Bob Coghill, where these individual differences are being contributed. And what we've learned, the short version, it appears to be mostly related to brain circuits, meaning that we may all be transducing the same nociceptive input, the same input for a given stimulus, but when it hits the brain and it gets amplified or turned down, that's where our individual differences come about. One of the features, one of the contextual factors responsible for pain is something called fear avoidance. It's a model that is built into all of us that when we have persistent pain, we learn to avoid any type of stimuli or activity because we get fearful it's going to increase our pain. And it can get into this ever worsening cycle. Some of the earliest brain imaging studies I did were to look at these brain correlates of this fear of pain. We mapped this into the areas of the right lateral orbital frontal cortex, this area right here over your eyeballs. This is involved with evaluating incoming inputs, making decisions about them, about what you're going to do. We've also done a lot of work in the area of chronic pain to understand what happens in the brain when people have chronic pain. And in this particular study, what we learned is the following, that we have these networks in our brain, all of us, that are there at rest. One of them is called the default mode network. It's involved with quiet, restful thought when we're sitting there and our eyes are closed and we're not doing anything and we're relaxed. And we have another network called the central executive network when we're thinking intensely or focusing on something. What we've learned with chronic pain, in this case back pain, is we have increased connectivity between the amygdala, an area involved with fear processing, and that central executive network, and a reduction in connectivity to that default mode network. Meaning, when people have persistent pain, they're stuck. Their brain is stuck into a state in which they're focusing attention on that pain all the time. And what we do with a number of our therapies is we work to unstick that brain. And I'll get back to that later. Now, it's not all bad news. I did a study a while ago on the role of love in pain. And the reason is I wanted to study the reward systems involved with pain because we know that these deep old structures and regions in the brain involved with evaluating reward play a classic role in modulating pain. They're high in dopamine, which is, people think of it as a rewarding type chemical. It's more complex than that. But what we did is we recruited Stanford students in a deep, passionate relationship. We brought them in. We had them bring photos of their beloved. We caused them pain. And we measured how much pain they had. The long and the short of it is, pain is a great drug. It's a tremendous drug. Excuse me, love is a tremendous drug. It had significant reductions in how much pain that patients had, that people had. Now, what does this mean for taking care of patients with pain? Because we can't prescribe a passionate love affair for everybody. That won't work. But what we've learned is that if we can activate those reward systems through activities, through things that we're enjoying or thinking about, that it can have a deep, profound reduction in one's pain. We've also learned, extrapolating this, that social connectiveness and bonding with people has a tremendous analgesic benefit. And our more recent research has shown that time and time again. I want to pivot a bit towards how we assess and manage the person with chronic pain. I'm going to be focusing on what we do at Stanford, but this applies with other major academic centers and perhaps other community centers you may be near. What we have found is that a multidisciplinary or interdisciplinary approach is frequently the best. It simply means bringing to bear different types of treatments all together at one time. We use medications, procedures, these are interventional procedures or surgery, psychological behavioral approaches, physical and occupational therapy, complementary alternative medicine, and then also personal management. I refer to it as the 6 pillars of multidisciplinary pain. And breaking each of these down, first, everything starts with a proper assessment. One of the things that we do a lot at Stanford is we bring people in with a clean slate. We appreciate they've been diagnosed with something, but we want to be proven that it's actually what they've got. And so the key is always in the medical history, supplemented by physical exams, and then, if needed, additional imaging studies or other studies to augment that. From that, we can choose from a cornucopia of polypharmacy. What I mean by that is, over the last 25 years, we've seen an explosion in the number of medications that have pain relieving properties. Now, when people think of pain medications, they almost always jump to opioids. And one of the key messages I want to give you is, of the 200 medications that we can bring to bear to treat pain, only 20 are opioids. The other 180 are non-opioid medications. The other key thing that I want to show you in this slide is that each of these medications attacks these pain processing pathways at different places. And so we have medications that work out in the periphery. They don't knock out pain primarily. What they do is they knock out nociception. And remember, if you've got less nociception, less of these signals out here, you're certainly going to have less pain. But the vast majority of medications that we use for the treatment of pain actually don't work out here in your body at all. They have no impact. They're all working in your brain and in your spinal cord to turn down those circuits that I showed you before. And what you'll find in our world in pain is we steal from every other field. We steal from the psychiatrists, their antidepressants. We steal from the neurologists, their anticonvulsants, the cardiologists, their anti-arrhythmia drugs. And what we find is that they're frequently better pain medications than what they were originally FDA approved. And maybe we'll talk more about that in the Q&A. We do a lot. There's over 200 interventional procedures that we can bring to bear to knock out nociceptive impulses out here, to modulate things in your spinal cord, or to work in your brain. We also have a tremendous number of physical and occupational therapy approaches to help people with increasing endurance, strengthening, education about pain, setting goals, and pacing. All of this has a tremendous impact in helping people get back to the quality of life that they want. We involve heavily psychological and behavioral therapies as well. And this one's a little bit more challenging, I think, for people, because we all have this image of the person on their couch asking about their relationship with their mother, and that's not what we do. We're all about skills. It's about teaching you skills that you can take back with you to learn how to better address your pain. I'm an engineer by original training, and I refer to the 7 psychologists that we have in our group as brain hacks. What they're doing is helping you to learn how to hack those brain circuits and giving you skills, and it works. The data is unambiguous. We use complementary alternative medicine approaches like acupuncture, mindfulness-based stress reduction, a number of over-the-counter, what are called nutraceuticals. These are simply agents that you can buy in a vitamin store that have shown in randomized controlled trials to have benefit for pain. And again, the data is overwhelming, going back decades, that when you combine all of this together, you're going to get a better benefit than just trying one thing at a time. So I want to now pivot just a little bit and talk about our center and the resources that we bring to bear. Our mission statement is to predict, prevent, and alleviate pain through science, education, and compassion. We are one of the largest interdisciplinary comprehensive pain centers in the United States. We see now over 30,000 patient visits a year. I've got 30 faculty in our group, all boarded in pain medicine, coming from different specialties in medicine, primarily having learned additional training in pain medicine. And we also have including psychologists, acupuncturists, addiction medicine, physical therapists, dietary, you name it. And we all work collaboratively in one location, one physical location. One of the novel things that we do here is we're very data driven. We track everybody and how they're doing with their pain, and we use that data to help inform us. I'm going to share more with you in a bit, and we have a strong connection with our research group. We have built what I refer to as an interdisciplinary base of all those resources and then subspecialty pain programs around it. Facial pain, headache, GI pain, pelvic pain, many other programs that we can bring to bear with specialists. And we've been working hard to better serve the San Francisco Bay Area. I used to believe we should just have one site in Redwood City and let everybody come to us. That was about 20 some odd years ago. And then when the traffic got out of hand, I realized we couldn't do that. We had to go out into the community and serve people where they're at. So we've put multiple network sites, over 8 at this point, throughout the Bay Area, the East Bay, the South Bay, you name it, and we're growing. So I want to pivot in the last few minutes and share with you some things that I and our group are particularly excited about, and ideally give you some messages of hope. And I want you to imagine a world, I invite you to imagine a world where your unique data is coming in and we're using that unique data to help better choose the right treatment in the right circumstance for your pain problem. That is our mission, which is precision pain medicine. The problem that we have is that when we look on the advances in knowledge, it's like these little raindrops, each of these raindrops being a published randomized controlled trial, each contributing to our overall knowledge, but doing so rather slowly. How slowly? It's a sad fact in our world meaning medicine across all of the planet, that it takes on average 17 years for research findings to impact patient care. It's worse than that because it's 17 years for 14% of research findings to impact patient care. It is moving at a glacial pace. And I sometimes wonder, as I'm getting older, are we actually making an impact? And I'm driven, my personal mission is to make an impact on the lives of people with pain. We can learn from others who have used data, which is going to be the main driver, the main lever we're going to be pulling to make impact. They've been able to use data to make huge impacts. The Framingham Heart Study out of Massachusetts is one of those. 4 generations of families that have been tracked over their lifetime. And from those studies, that real world data, we learned the key drivers associated with cardiovascular disease, sedentary lifestyles, obesity, hyperlipidemia, hypertension, all of these that are modifiable. It has been absolutely transformative. We need to do the same thing in getting high quality data in real world patients. One of the challenges in our world in pain, it's really complicated. This is actually a simple diagram, but it's meant to be a bit of a shock and awe. Don't bother reading it. The point of this is that no physician can keep track of all this information in their head, and it's only growing by leaps and bounds. The National Academy of Medicine recognized this problem with the complexity of data and putting it to use several years ago. They put forward a notion of something called the learning health system. These are software platforms where we bring together patient data and we have teams of physicians, scientists, engineers, patients, policymakers, administrators, and where the data is continually being updated and we're learning from it. And we're putting the data to use directly for the person in front of us. Instead of those drips and drabs, we have knowledge as a force that is advancing all of our knowledge in a more rapid manner. That's what we did at Stanford. I created a open source platform, open source meaning free platform called Choir, where we integrate it into our clinical care. We track every patient who comes in, and we use that for clinical decision support. So we have people, once again, Susan, who comes in with these multiple pain problems, and we ask ourselves, how do we know what the best treatment is for Susan and whether we've actually made Susan better? Now, the key in developing these novel models and integrating AI and all the latest technologies is we don't want to end up in this situation. We all recognize this, where I see your heart rate variability is down, you're not sleeping, you haven't exercised. Have you tried not being in pain? No. You're not going to be treated by pain management AI bots. What we want is this information to be used to augment or support your clinicians in working collaboratively with you. And so in one way I'm going to show you with Susan, she comes in, we see that when she first comes in to see me, she's got higher levels or worse functioning in every domain. She's got high levels of depressive symptoms, anxiety. She's fatigued. Fatigue is often associated with fibromyalgia. Her physical function is poor. She's got severe interference to her pain. What we put her on is a medication called low-dose naltrexone. It's an old drug that used at a different dose has a novel property. I've studied this in several randomized controlled trials in fibromyalgia. It has almost no side effects. It's dirt cheap, and we give it out all the time. And it's not very well known because there's no pharmaceutical company that is promoting it because you can't make any money on this. It's off patent. We gave her that. I did that brain zapping, the transcranial magnetic stimulation. We gave her something called empowered relief. And if you stick around for this series, you're going to hear my partner, Dr. Beth Darnell, talk about empowered relief as a single session behavioral treatment that gets great impact. And what we found is significant improvements in all domains of her mood, her fatigue, everything except physical functioning. And we were able to use that lack of movement to guide our next approach, which was the integration of functional goal setting. Where our group at Stanford is moving with this is to integrate in biomarkers. And so we're developing individual signatures of your pain, and we're putting all this together into complex AI models that we integrate into this learning health system. And we're using that to then deliver the best treatment for you in your circumstance. Where I'm going with this is a personal mission is I want to spread this out to the rest of the world, ideally give it away. We recognize there's huge swaths in California and elsewhere that are undertreated and can't get to Stanford or other major academic centers. And we want to get out to them using these types of technologies. If interested, come and talk with us about it. And in that, if you want to learn more about what I've been talking about, I did 2 recent podcasts that are readily accessible. One with the Huberman Lab, where with Andrew Huberman, who's a faculty member here. He's an amazing podcast. These are both amazing podcasters. We talk more about the neuroscience of pain because Andrew is a science geek around neurosciences. And then I just did Peter Attia's podcast where we focused more on treatments. Peter is a superb physician, and we focused more on the medical aspects of pain there. I invite you to listen to those podcasts of interest. With that, I'm grateful for your time. I hope this information is of use and can help empower you. And I want to leave you again with a message of hope. There are exciting times ahead of us in the area of assessing and managing pain. Our goal is to get these newer, safer, and effective treatments into your hands and be able to help you and other people out there suffering. With that, thank you. Delighted. And I'm going to just moderate this. I talked with Gene, and I'm going to get through some of the questions. Can I share your slides? Yeah, I can. I can fire off a PDF and provide those for you. Delighted to do so. And Gene, if Gene has a way of posting them, we can do it. And if Gene can't post them, I can post them and get Gene a link where you can download them. So we'll make that happen. The low-dose naltrexone dosages for trigeminal neuropathy. We haven't studied this in TN, trigeminal neuropathy, yet. We have given it out in many of these neuropathic pain conditions. The typical dose is 4.5 milligrams. Now, the truth is we made that up. It was a direct conversion, milligram per kilogram, from a mouse into a human. There has been no real dose-finding studies on this drug because, again, there's no money to study it. The good news is it's incredibly safe. So I've used it at 4.5, I've used it at 10. The standard dose is 50 milligrams. It is used to treat alcohol and opioid addiction. At 50 milligrams, it blocks the opioid receptor and blocks the rewarding aspect of it. At these low doses, what it does is it blocks something called the glial cells, which we didn't get into. I believe Dr. Tawfik is going to give you a talk on complex regional pain syndrome, and she is Dr. Glia. She's amazing when it comes to the glia, and she'll talk your head off about glial cells. The glial cells are these neuroimmune cells that surround our nerves. They surround them and they modulate the signals. And what happens during an injury is these glial cells activate, they release all sorts of inflammatory chemicals, and they wind up your pain, and they cause that illness behavior that we all get after getting, for instance, a cold, where we just want to lie on the couch and have somebody bring us a little cup of hot cocoa with the marshmallows. That's a hardwired program that's in part due to those glial cells. Naltrexone at low doses blocks that. And so we found it helps with fatigue, sleep, mood, and of course, pain. Why are some doctors hesitant to prescribe LDN for chronic pain? Great. Because we're conservative. It's as simple as that. I don't mean politically conservative. I mean, rule number one when we got into this profession, do no harm. And so this is a rather esoteric medication that most doctors are not familiar with using it in this way. And so as physicians, if we're not really comfortable with knowing what a drug is doing, we prefer not to prescribe it. What we frequently find is that if a doc sends us a referral to a patient and we evaluate them and recommend low-dose naltrexone, we can either initiate it or we will give them messages back with education on how to do it. And we found that we can work collaboratively with docs. That often works. We share slides. Yes, I address that. Thank you. You're quite welcome. Have you used TMS for trigeminal neuralgia and neuropathy? Yes, we have. And the thing with TMS is we get variable responses with it. Some people get tremendous benefit. Some people get no benefits, like almost every other treatment that we give for pain. We're still trying to figure out who are going to be the responders and the non-responders. The nice thing about the TMS, it's got really almost no side effects. Please provide some natural remedies for chronic pain versus the pharmaceutical approach. Our country is unique in that many years ago we passed a law that allows over-the-counter selling of herbals and nutraceuticals that in other countries would be considered a prescribed drug. One of those is acetyl L-carnitine, which is a over-the-counter agent you can buy at Vitamin Shop, GNC, Amazon, pick your choice, and at high doses, around 2 to 3 grams, it actually has disease-modifying properties on your nerves. It's been studied formally in diabetic neuropathy, and it's been shown to increase nerve conduction velocity in people with diabetics. And it's been shown to reduce peripheral neuropathic pain. Alpha lipoic acid is another one of those agents that had some pain relieving property in nerve pain. Also, typically they're given at higher doses. You need to be mindful of the alpha lipoic acid because it also is a T-type calcium channel blocker. I tried it for a while to see what it was like, and what I found is it was capping my maximal heart rate when I ran. I just couldn't get my heart rate over 150 on it, so I stopped it. But for some people, and I don't have neuropathic pain, but I wanted to see what it was like. It's a safe agent. Vitamin C, very useful if you're going in for surgery that's going to involve your nerves and reducing the likelihood of developing persistent nerve pain. Fish oil, because the omega-3s are shown to be very helpful for the lipid bilayer membrane around your nerves, and there's other agents as well. Let's see here. I want to know more about pain management and different points of view, especially in the oncology field. Well, the thing is, every doc and every specialty has a different way of looking at people with pain. And it's a problem that we have in the medical field. We're not going to solve it today, but it's helpful for you to be aware of it. We all look at patients through our own lenses, and we see them through the areas of expertise that we bring to bear. And you can think of it like that Indian parable of the blind men and the elephant. You know, one person is grabbing the trunk and thinking it's a snake. Another one's grabbing the leg and thinks it's a tree. The key is we need to look at the whole elephant and see the elephant in the room for what it is. That's the person with chronic pain, and look at them from a holistic standpoint. Frequently in the oncology field, and I'm overgeneralizing here, so forgive me, is the primary focus is in keeping people alive. And the oncologists have been superb with that. Major improvements, thank you to the NIH for funding this, in keeping people alive. What we're now faced with is people get chronic pain after those treatments. And the oncologists frequently don't know what to do with that. So they send them to us, or people are kind of stuck on their own. And I'm sorry for the person who wrote that if you're one of those people. How benign is taking 1,500 milligrams of acetaminophen in 300 to 500 milligram doses for a senior sarcopenic woman? I want to be careful to not be giving direct medical advice here. We typically say stay under 4 grams a day, 4,000 milligrams. Some are saying 2,000 milligrams of that. The 1,500 generally seems okay if you have decent liver function. That means that if you don't have hepatic or liver impairment, you're not drinking a lot of alcohol, which can cause liver impairment. It's generally thought to be safe, but that's a great question to ask your primary care doctor. Who are the team members serving the GI and pain clinic? On our side, many of our docs are focusing on GI pain, also pelvic pain. Krista McKenzie, Jennifer Ha, I think one or both might be giving a talk here. Focuses a lot on pelvic pain, but there's a lot of overlap with the pelvic pain and GI pain. On the GI medicine side, we have Linda Nguyen has been our go-to person for that, and they've got a great team of docs on the GI side. Do antidepressants mitigate pain receptors, nerve pathways? Yes, you're spot on. And this is an area of frequent confusion, is that when we prescribe an antidepressant, people will say, but I'm not depressed. And maybe you're not, but we're not giving it to you for depression. A number of the antidepressants, particularly 2 classes, one called tricyclic antidepressants, the other one called serotonin and norepinephrine reuptake inhibitors, both act on 2 groups of neurotransmitters, norepinephrine and serotonin. These neurotransmitters are in our brain and in our brain stem, and they're primary neurotransmitters around pain perception and pain modulation. That means turning it up and turning it down. So we find that these two classes of antidepressants can have terrific pain relieving properties independent of any effect they may have on your mood. And that's why we use them for pain. We do the same thing when I mentioned to you we steal from the neurologist their anticonvulsants. Remember, anticonvulsants are stopping seizures, which is overactivity of electrical activity in your brain, right? Well, don't we want to reduce that overactive electrical activity in the pain circuits? And that's where medications like gabapentin or pregabalin and others come into play. It turns out gabapentin, which we use frequently for pain, is a lousy anti-seizure medication. It really isn't very good. And the neurologists don't use it much. But it's a great pain medication with relatively small side effects. Can medications increase your pain? Yes, they can. It is an unfortunate side effect that can occur with medications. It's highly individual, and that's where they just need to be titrated one at a time. This is one of the reasons why I don't do lots of things at once to people, because many of the medications that we have can have side effects, can cause increase in nausea, fatigue, sleepiness, and in some cases, worsen one's pain. And it's better to do it one at a time. There is a controversy around opioids about whether opioids can induce something called opioid-induced hyperalgesia, which is an increase in pain when you're on opioids persistently. It's been shown in animal models. It's been shown in acute surgical pain models in humans. There is a high belief that it exists in the chronic pain space. We have had a real hard time from a science standpoint demonstrating it and showing it consistently. Let's see here. Other questions. Being a support system for friends with chronic pain. Beautiful. Thank you for that question. In the last several years, probably the big wave of interest and knowledge that's been hitting pain has been around social functioning and social isolation. I took a lot of that data we collected through Choir, and I did some, it's called Bayesian network reconstruction. We basically threw it into an algorithm, and we told the algorithm just find the things, the features that are most contributing to somebody's pain. I had all these hypotheses what it would be. I was wrong. In fact, the big one that showed up was social isolation. We then took that data and we did a modeling of it, and we found social isolation was coming up over and over again. And it's really changed my perspective around pain. We've introduced peer-led support groups at Stanford that bring people together under a leader who has chronic pain and who has been trained in how to give people skills. We find they work really well. My message to people is try to stay engaged with friends and family, because the natural inclination is to withdraw. It is, we're all wired like, dogs or cats who, if you have an injured paw, what does a dog or a cat do? It goes into a dark corner and it just sits there until it heals up. But the problem with chronic pain is it's still there. So that wiring in our brain is telling us to withdraw and to isolate. And what the data shows is that's the worst thing to do. is to stay involved with friends and family in your community. And if you have a loved one with chronic pain, lean in, help them to stay engaged. The question here is how to be also a support system. I think the other thing is validate what they're experiencing. I think one of the biggest challenges that people with chronic pain have is they feel invalidated or not believed because it is frequently an invisible disease. You may not be able to see an injury or see why they have pain, and therefore we project our own understanding of pain onto them. Just accept what they have, be supportive, help them to stay engaged. Um, Personality traits, perfectionism, and chronic pain. Yeah, this one, this one has been studied over decades, and mixed data on the whole personality traits. There was data back in the 80s, 90s that suggested that there was this pain personality. I think it was overly simplistic, overly reductive. Um, there are interactions between different personality characteristics and having chronic pain. And it can be counterintuitive. There are characteristics that are really adaptive for all of us. You know, all physicians are kind of OCD, and a lot of the people in the Bay Area are OC, have a bit of OCD and are highly driven to, perfection and hard work. And that's the model that gets people ahead. And it works with chronic pain up until it doesn't. And then things fall apart. And the challenge is unlearning some of those characteristics and learning more adaptive coping strategies for your pain. Uh, that is one example. Um, I'm a former engineer. I know engineers. They're some of the hardest people I have to care for. I love engineers, but boy, oh boy, are they linear. Everything is about, you know, linear systems find the nociceptor, knock it out. And unfortunately, it's just not that simple. So the more that you can open your mind to this complexity of pain, that yes, there may be something going on out in the body, in the periphery, but it's modulated by your nervous system, your spinal cord, your brain, and these descending pathways. And learning that we need to hit all those pathways at once, and that it's not like a nice, clean system that we can characterize like an engineering system is going to put people ahead. Yeah, there
Dr.
are.
Mackey?
Yeah, we
Thank
at time.
Yep. Yep.
Okay, we didn't get to the redheads, but yeah, there is good data on redheads. It doesn't make a huge difference. We make a big deal of it, and from a science standpoint, and there are genetic reasons, um, uh, but still a lot of variability even within redheads. Gene, back to you.
All right. Well, thank you, Doctor, for this great presentation. It was fascinating. I also like to thank our audience for joining us tonight and for these great questions.
Yeah,
If you'd
thank
like,
you.
yeah, if you'd like additional information or resources or the studies on redheads or whatever have you, contact Stanford Health Library. And we also hope that you'll join us for our next lecture. Good
Thank
night.
you all.